Good evening, everyone. Welcome back to Dent Links. I'm Dr. Peter Tawil. It's my pleasure tonight to present the Professor Nabil Barakat, who is joining us on this webinar. Um, and he will be talking tonight about the necessity of sinus lifting. Professor Barakat is the former chairman of the Department of Oral and Maxillofacial Surgery at the School of Dentistry at the Lebanese University. He's a graduate from the Loyola Dental School in Chicago and the founder and chairman of the Department of Oral and Maxillofacial Surgery at the Lebanese University. He is also past president and has occupied many positions, among it president of the ICD and many other associations. Professor Barakat is a pioneer in implant dentistry, and it's a real honor and pleasure to have you with us tonight, Professor. I hope you really enjoy the lecture. And Professor Barakat, the floor is yours. Thank you.
Thank you, Peter. Good evening, everyone. Today we have an unusual subject, which is sinus lift an absolute necessity? Why is it unusual? Because for the surgical management of the posterior atrophic maxilla, the lateral sinus floor elevation procedure is the gold standard for many surgeons. But it has three drawbacks. The first one is the possibility of an undetected intraoperative maxillary sinus membrane perforation, like you see on the first slide, and with the resultant sinusitis. The second drawback is acute or chronic sinusitis following a sinus lift procedure. Why I make the difference? Because in acute, it is within a week, you can under local anesthesia, apply the basic principle of surgery. When you have an infection, you have to remove all foreign bodies. While in chronic, like in this case that was operated 2 months ago and put on antibiotic for 2 months, this is the X-ray I received. And when I asked for a CBCT, you can see the infection are in the sinus with the destruction of bone around the implants. And then in chronic, you have to have an ENT collaboration. On ENT exam, you can see how the maxillary ostium is obstructed. Therefore, under general anesthesia, you have to work, you clean up the whole area. This is the cleanup sinus after cleaning all the granulation tissue. You can see the floor of the sinus, and you can see the implants removed. For basic principle, remove everything from the sinus. And you can see, as we said, you have to have an ENT with you to do what we call a functional endoscopic sinus surgery, where he will open and clean everything. And I've noticed that when you do this under local for acute or under general in chronic, you always obtain some bone when you see the patient 6 months to a year after, like in this case, and you could put some short implants. Now, the third drawback is the timetable and cost factor when you see it. If you do an external sinus lift, you need between bone regeneration, osseointegration, a prosthetic part, plus the cost of harvesting bone substitute, and membrane, you need around 12 months. While if you use classical implantation, within 4 months will be finished between osseointegration and the prosthetic part with no additional expenses. Now, what's the KISS concept? The KISS concept is patient wants implant faster, less traumatic, less expensive. That is, it is within the trend all over the world, minimal invasive surgery. Are there alternatives to sinus lift? Yes, there are. But when do we decide for a different treatment option? Patient's age. In patient over 60, usually I don't do sinus lifts because it takes too long. By the time we finish, the patient is getting older. Patient's habit. We know that with smokers, you get an infection rate of 42%. Patient desire. Patient tell you, I don't want you to touch my sinuses. Patient individual health condition. In a medically compromised patient, try to avoid sinus lift procedures. This is a case where it was really my mistake. I knew already that in reoccurring sinusitis, you should not do sinus lift. But I've asked for a scanner and the sinuses were cleared. I went ahead and did the sinus lift and I paid the price. Within a week, the patient had an oroantral fistula. And when I open it, you can see it on X-ray here, how on one side we have an open sinus on the right side, on the left side, and on the right side we have a acute sinusitis with the ostium completely blocked and all the bone substitute parading in the sinuses. And on surgery, we were shocked to see such a large bony defect. The only way to close such a defect is to make an incision and deliver the second molar in the periosteum, dissect the buccal fat pad, la boule de Bichat, and you have to dissect it and not pull on it because you have to keep the blood supply on it. You suture the buccal fat to the palatal mucosa and then you close over it. And this is the result after 5 years of CNR. Now, alternative approach, every surgeon should have in his armamentarium many surgery. Because otherwise, for every patient, when you have a hammer, you think it's a nail. And you have gonna apply the patient to the technique and not the technique to the patient. Therefore, you have to have many techniques, but because of the limited time I have, I will discuss today the implant placed posterior to the sinus. What's the principle? The principle is use all available bone. We have in the posterior region 3 types of implants we can place. In the tuberosity region, in the pterygomaxillary implants, and the zygomatic implants. If I review the anatomy a little bit, in the maxilla, we have the tuberosity T, we have the palatal bone P bay. We have the palatal bone has a process called the pyramidal process that connects the tuberosity to the sphenoid bone, where you have the medial and lateral pterygoid plates. We should not forget that in the posterior region, the amount of bone histomorphometric is 7%. Therefore, it's very little bone and a lot of osteoid tissue. What's the treatment planning? When I decide which one should I use, you have to have a CBCT. On a CBCT, if you have a tuberosity, you do a tuberosity implant. If you don't have a tuberosity, you go to the pterygoid implant. And if you have an extreme atrophic maxilla, you go to the zygomatic implants. The tuberosity implants. If you follow the protocol, I think everyone that's listening to me can use this technique safely. Because anatomically, there's nothing to be scared of. There's no artery, there's no vein, there's no nerve there. But you have to follow that protocol. One, you have to, with the CBCT, be sure that the tuberosity, anatomy of tuberosity is favorable, like here. 2, you have to make a midline incision and expose palatally and buccally. But what most surgeons do, they make a midline incision, they reflect the mucoperiosteum buccally, and when they start using an osteotome, they will be in the buccal wall and they'll get fracture of the buccal bone. You have to expose the whole tuberosity, if you can posteriorly, palatally, and vestibularly. Then you don't use burrs in the area because already 7% bone. And you know that every time you use drills, what will happen? Some bone will come out with it. Already it's 7%. Therefore, you use osteotomes. These are the rounded one, not the one for internal sinus lifts. And you start with the 2 millimeter, 2.5, 3, 3.5, and you stop 1 millimeter less diameter than the implant use. Very important. We taught you, and we teach, that you put your implant at 45 to 50 Newton centimeter. But don't forget, this is in the good bone. When in external sinus lift, in internal sinus lift, whenever the bone is soft and you don't have a quantity of bone, you tell the nurse to lower the low torque to 20 to 30 Newton. Why? I don't want my implant to go in quickly and be unstable. I want it to go with difficulty to go in. I give you few cases, long-term result, like this case, where you can see a good tuberosity, and then I can use osteotome sinus floor elevation. This is what we got. But this is interesting. This is the case. Sorry for the picture because these are, when you see it before 2000, it was analog. It was not digital picture. You can see in 94, you can see few years after, 6 years after. You can see when I put on the other side, 15 years after. Last time I saw him was 22 years after. When someone show you a new technique or whatever it is for you, don't accept if he doesn't show you long-term result. Because why should he, you say bravo? He didn't do the laboratory, but I want to know what happened to the soft tissue around the implant and what the level of bone around the implant. Look at this case. She was 69 when I saw her. This is 1 year taken post-op. I've placed 2 implants on the left side, but I lost one and the patient refused to have a second one done. Therefore, we had to connect it to a molar, which is not advisable. But I didn't do a sinus lift on this case. As you see, she was already 69. This is 1 year post-op. I used a tuberosity implant. You can see 10 years after, and then you can see 16 years after, and you can see the age change around the lower premolars. Okay? Therefore, in patients, elderly patients, try to avoid to do sinus lifts. It's much simpler to do a tuberosity implants. Now look at this case. Heavy bruxer, heavy smoker. I asked to do a sinus lift. He refused. Therefore, I tried to put 4 implants on the left, 3 on the right. I lost 1 because, of course, I didn't have enough bone. Then his prosthodontist told me, no, he's a bruxer and a smoker. I won't do fixed prosthetic. I will do what he did on this case, fixed removable procedures with Sika attachments. Therefore, the patient accepted it. He was not very happy. And then after a couple of years, he said, no, I want fix. Therefore, I told him, okay, on 2 conditions. We will have to add more implants, plus you have to wear a night guard at night till all the implants are placed. Therefore, CBCT, this is the fixed one. A CBCT, we were sure we had a nice tuberosity, as you see in these cases. Okay, always osteotome, right and left. And this is the x-rays. And a second stage, and this is the fixed case. If you see on the right side too many implants, but some American will tell you, oh, it's too many implants. You tell them, okay, this is a bruxer. You say, okay. But if you see a German tell you should have had more implants. And then bruxers, how do you recognize them? They start crackling their porcelain, as you can see. And then they fractured the first molar. And of course, if you plan to put implant after extraction, you have to do some site reconstruction. And then in this case with Dr. McGarvany, we put bone substitute and bioresorbable membrane. And you can see a few months later, the bone we obtained. We had a nice ridge, and we place we usually, for molars, when you have 14 millimeter, we use 2 implants. This is 10 years after. The molar is 4 years after. This is 14 years after. He broke the second molar plus the anterior teeth. We saw him 19 years after. You can see here, the upper one are 20 years, 6 years for the anterior, and 14 years for the molar on one side, and 6 years for the molar on the other side. And then he disappeared. Last week, 2 weeks ago, the wife called me, told me he had a stroke, that's why you didn't see him. But the dentist insists that you place an implant for him. Therefore, we had a hell of a time getting him in 17 years after for one molar, 9 years for the anterior, 9 years for the other molar, and 23 years for the tuberosity. And you can see how the upper right implants are distorted because we had to hold them, to have the panoramic X-ray. Now, I'll show you 2 cases, new, but we had no choice except doing tuberosity implant. Some friend of mine extracted that tooth, had an oroantral fistula. He sent it to me. I closed my buccal flap. And then he came a few years after showing this X-ray and this X-ray. And you can see here on the X-ray, I should have marked it, that once you have an opening in the bone, it never closes unless you put grafts. How did we know that? When we used to reopen after the Caldwell look, the opening was there. The only place for the opening to close is to put a bone graft. Therefore, I was not very happy about doing it, but they insisted. Therefore, I went ahead. You can see this is the case. And I had to dissect it. I was very proud of my split thickness dissection of between the membrane and the soft tissue. Okay, you can see it here. Very happy with myself. I thought I was Captain America. And then catastrophe. 1 week after, 3 weeks, 1 week post-op, he came with dehiscence and some of the bone substitute has left. Therefore, I asked his dentist to make an obturator for him. And you can see here with time, 2 to 4 weeks, we had healing by secondary intention. And then what to do here? What can I do? I know there's an opening still there, okay, because the bone fell from this area where the opening was. Therefore, the only way to get away with it is to put a tuberosity implant. This is what I did, okay? This is 5 years post-op. The second case, a patient who just came from a dentist and he had paid $12,000 to do his whole full mouth reconstruction, but when I saw the X-ray, we were shocked. He did the reconstruction leaving the molars in this status. And of course, I proposed to do sinus lift for him, which he refused because he said that the dentist showed him the video of the sinus lift and he was scared and refused sinus lifts. Therefore, it did, after studying the CBCT, nice tuberosity. This is the reconstruction that made by Dr. Abu Jawde. And then what to do in the back, you can see it now. We had to put 1 implant in tuberosity and 2 implants in different axes along the sinuses. And you can see it here 3 years after. Therefore, we studied 280 implants. We had 2 failures, but the failures were before we used the osteotome technique and the placement of microtexture implants. The pterygoid implants. The pterygoid implants, when you don't have a tuberosity, therefore you have to angle the posterior wall of the maxillary sinus, allow you to place an implant of sufficient length that insert into what left of the tuberosity region and terminate apically in the pterygoid process of the sphenoid, like you see in this case. Therefore, the first case we had, it was in 86. It was my second or third case in Lebanon. Patient has a Papillon-Lefebvre syndrome. What they do? They have a palmoplantar keratosis. They exfoliate the deciduous teeth at age and the rest of the teeth later on. By 14, she was edentulous and wearing a denture. And you wouldn't believe it when you check the x-rays. You never think she's 17. You say probably she's 80. Therefore, contacted PI Brandmark, who told me, okay, I'm going to check in my series. He said, I have 50,000 implant, no case of Papillon-Lefebvre. Do the lower and send me the upper. Therefore, I said, well, I had enough experience to check. At the time, we didn't have scanner. We had tomograms. And the radiologist was not very happy about doing it because, you know, the cathode cost $50,000 and he had to use it for 1 hour to get these pictures. I had learned from Jean-François Tulane. I saw him doing a pterygoid implant. I saw the pterygoid plate, they were thick. Therefore, I said, what should I send them? But when I took the course in 86 with PI, he told us forbidden to penetrate the floor of the sinus or the floor of the nose. Therefore, we did the Le4-1 incision, and I saw the implant coming in, reflected the nasal mucosa, placed 5 implants. What I'd like you to do, watch out the level of the head of the implant in the mandible. Remember where it was. And then a year later, she was wearing the Swedish boat, which if it comes to me, if I need implants and prosthetic, I will ask for the Swedish boat, which is the safest up to now. Therefore, we did anyone, they didn't tell us anything about angulation. So that one of the implants they could not use. You can see the case in 87. 17 years after she came to change the prosthetic parts. 21 years after she came back to do the prosthetic part again. Then 24 years after, she called me crying. She had an operation at the hospital under anesthesia, and you know when they use the Macintosh laryngoscope, they take fulcrus on the lower, on the anterior teeth, and she told me they broke my implant. I was really upset about it. But when I saw the X-ray, it was the screw that was broken, and it reminded me what PI told us while we were traveling with George Tawil and him introducing implant in the Middle East. He told us a good system is a system where the mechanical part of it is weaker than the biological part. The biological being osteodegradation. So that if something has to break, is the gold screw first of the prosthetic, then the abutment screw of the abutment, and not the implant. Therefore, contact the company. This type of abutment were not used for at least 20 years, and they send them to me 4-week working day. I saw her 32 years after last year. She came to change the prosthetic part. We took pictures of the case, and Dr. Hetti did a zirconia reconstruction of the case. And this is an X-ray 32 years after. Therefore, as I said, you don't believe anyone who tells you or show you a new technique without showing you long-term results. And we know from experience now that all the problem with the implants start 7 years after implant placement. And if the first year is okay, you'll have no problem for 7 years. And then if you have some little resorption around the spirals, it will be after 7 years. Look at this case. His patient had a cyst there in the lesion. What should I do? If I have to graft the sinus and graft the ridge, therefore we go for the pterygoid implants. And here he came back 5 years after he had a tuberosity. I went for the tuberosity implants. Another case sent to me. You can see the infection around the molar. By the time you extract the tooth, you're in trouble because you have that type of lesion. Therefore, go for the pterygoid implants. This is 3 years after, and you can see the lack of tuberosity and how the implant goes behind the sinuses into the pterygoid plates. And this is 16 years after, and then I lost the track of the patients. The zygomatic implants. The zygomatic implant is an implant that we penetrate in the premolar region and hook it in the incisura where you have the arrow. This is called incisura into the zygomatic bone. Patient came to me in 86. I didn't know better. I placed 3 implants, which you never do. You should use 2 only. 3, the prosthetic will rock on the middle one. And then she told me, I trust you now. Add more, I want a fixed one. Therefore, I put 5 for her. Then 10 years after she came, she had lost the upper teeth. We placed the implant and placed the prosthetic part. And the day we placed the prosthetic part, she left for the States where her son was a physician. And he told her, did you do a test for osteoporosis? She told him no. He said, okay, go ahead. And then he started her on bisphosphonates. She came back a few months later, having lost 4 implants. Then she lost the 5th one in the maxilla, and in the lower one, nothing. Why? Because in the lower one, we had reached already a steady state where modeling equal remodeling. That is where bone is stable around the implant, while in the upper one, the newly formed bone was not really turned into lamellar, well crystallized bone. Therefore, what to do in this case? Use a 55 millimeter zygomatic implants. This is 10 years post-op, 2 years up, 13 years down. This is in 97. I saw her 16 years after in the upper and 27 in the mandible. And then walking next to the clinic a couple of years ago, I saw an old lady. I thought she disappeared, that she was at her son, which is true. She was passing by Beirut. I called her, she said yes. I took her up to my office, and I can see we both got shorter, very smart, sharp women. She had the same prosthesis for the last 30 years. She hasn't changed. She hasn't changed that prosthetic part. But look around the implant, how clean it was. There was 30 years after. And you can see here that our implants are designed for life, 30 years in the mandible, 19 years in the maxilla. And all we can do at the end is thank you, PI Brandbach.